Welcome to the Gyan Pravah Podcast Series, which is the initiative of our FOGSI President, Dr. Sunita Tandulwadkar Madam. Today, she's traveling abroad for EBG COG conference in Frankfurt, so she's not going to be with us. But we have two eminent personalities to have this podcast. So we have our FOGSI Vice President, Dr. Palanipan sir. As all of us knows that there are the few people whom you can directly coordinate with, and those are having immense knowledge in every subject. You have to just ask him what are the things that you need to understand, and he is the person who will tell you exact what to be done in a whichever prospect it may be. And another, we have our guest, battery low झाली. Dr. Mandeep Singh. So we will be going to have a podcast with him. Prior to that, prior to the introduction of our guest, I request our Vice President of FOGSI, Dr. Palanipan sir, to say a few words.
Hi Ashish, hi Mandeep. Good evening to all of you. And I'm very thrilled to be a part of this podcast series of Gyan Pravah, the most lovely portion of Dr. Sunita Tandulwadkar's presidentship. 8 o'clock, whether you're in the temple or whether you're at home or whether you're in the clinic, you could log on and the podcast goes on and on. And every chairperson of FOGSI is being involved in this, and they could interview anybody through this particular podcast series, whether it's an obstetrician, gynecologist, entrepreneur, a businessman, a politician, or anybody. And we would get words of wisdom from anybody who's specialized in their fields of interest. And that is the speciality or the distinctionness of this particular program, which Dr. Sunita has put forth. 8 o'clock every day, one chairperson does, and we've almost crossed 130 podcasts almost now. And 8 o'clock, we are sharp live with each other. And it is today Ashish's podcast, and Dr. Sunita is not there, doesn't matter, but podcasts will go on, and we are always here to help, and FOGSI is always there to connect with everybody. To come on to the other side and say, it's lovely to have Mr. Mandeep over here, and he will be sharing details with us, and I'm sure this podcast is going to be extremely useful for all of us, apart from the daily routine of laparoscopy, IVF, and breech deliveries and meconium sections and whatever. So it's going to be extremely different from what we are going to do every day, and so we're going to have a lovely time. And all the best to both of you, Ashish and Mandeep. And as it is a protocol that I log out of this and log into the general link, I would log on to that. And over to you, Mr. Mandeep and Ashish, for a lovely podcast. And it's wonderful being connected with you on this Gyan Pravah podcast. Over to you, Ashish.
Thank you, sir. Thank you very much for being there for this podcast as a guest. So we are without wasting much time, I like to welcome a special guest of today's podcast. He is none other than Dr. Mandeep Singh, and he is a consultant and subspecialist in maternal fetal medicine, the fetal surgery. He is a director of Cyprus Nicholas Fetal Medicine Therapy Center at Abu Dhabi. He is ex-medical director of Mid South NHS Foundation Trust in UK. He held several leadership positions in UK. He trained in maternal and fetal medicine in UK, Cambridge University. He has many publications for his repute. Welcome, Mandeep sir. It's an honor of mine to have you here on this particular podcast. Sir, whenever I previously I had taken the interviews of many political leaders, many of the entrepreneurs into a CA. Today, I'm very much privileged to take a podcast and interview of the person who is belong to Indian origin, now a British. In your CV, when I was going through, you said it is a British Indian uh, person who has achieved everything in UK. So coming back to your roots, that is a Kolhapur. You passed out from MBBS from Kolhapur University, and then you done your MD. Sir, all of us knows that after the MD, maybe at your time, there are the much more specialties like endoscopy or maybe a fetal medicine was not that much well developed. Because how you develop your interest into the specialty which was never heard of back in that time.
Thank you, Ashish. It's always a privilege to be part of any event of FOGSI. And thank you for inviting me. It's always good to connect back to India. You said British Indian, and I would probably turn it around and say Indian British because I had my initial training. I did my MBBS in Solapur, which
Yeah.
was under Kolhapur University, and then did my MD from the same university. And at no stage there was any plan or to go abroad.
Yeah.
Solapur, when I joined Solapur, very small town, an old medical colleges, a medical college, government medical college, and had a normal sort of transition through MBBS and then MD. I think what changed was post MD because majority of my friends or my colleagues who were in medical school who did post graduation went back to their own towns and villages to start practice. My father was in the police and we used to get transferred every 2 years. So I did not have a town to go back to. So I always used to ask myself a question, where do I go? Anyway, I have been in Maharashtra for many years, maybe around 7, 8 years at that time. And for me, that was my state, and that continues to be my state. I speak Marathi very fluently. So I
Okay.
tried getting into private practice. And I think, as with every newcomer, there are lots of challenges. The initial part of your life is very, very challenging. And I think that is the time when I thought I should probably do a bit more than just doing an MD and starting private practice. I know our training system is good for practical training, but I always felt that there was a gap between my training and probably where I wanted to be. And I think that led me to explore going abroad to fill that gap. I'm not saying in any way that the Indian training system is inferior, but I think
Mhm.
a complement of an Indian training system with a Western training system is much better.
Sir, just to tell you one thing, the Solapur has given us two diamonds now in the OBGYN field. One is our president of FOGSI, Dr. Sunita Tandulwadkar, and the second one is you. So both of you are having your own place in OBGYN. Saying so, sir, what makes you to go to the abroad and perceive into the fetal medicine or fetal therapy? Because if we go abroad nowadays, the people, young generation, they thought of doing the IVF in India, most of them, and most of them they wanted to go get into a endoscopy or maybe a endometriosis surgery. So, what in back in your time, how you find out this particular institute to go and train yourself, and what was the journey?
So I basically went to the UK to do MRCOG and probably worked there for some time. When I obviously for me, I had no idea what fetal medicine is because at that time for me, fetal medicine was probably giving protein infusion, and we used to send our women to operating theater to have oxygen because they had babies with growth restriction. And that was the end of fetal medicine as far as where I trained from was concerned. So I had no idea what fetal medicine is. And when I went to the UK, I was working in a district general hospital. And I met one of the consultants who had some training in fetal medicine. And he told me that he said that if you want to do something big or if you want to achieve something in life, you need to go and meet Professor Nicolaides because he has changed many people's life. And if he accepts you as his trainee, you will benefit a lot. So one day I decided that let me try this. There's no harm in meeting him. And that's when I went to him and my life changed forever. And then obviously the rest is all history. That's where fetal medicine started for me.
Sir, to all of us that now this audience is OBGYN mostly. Few of them are fetal medicine experts, but most of them are OBGYN. So, can you able to tell us what is the difference between the fetal therapy and what is the difference between fetal surgery and how the there is a evolvement of the ultrasonographic machines, how you evolve yourself into a diagnosis first and then the treatment modalities and now a surgery.
So let me take a step back and go into obstetrics. So fetal medicine is probably a misnomer. It is always maternal and fetal medicine. So our training in the UK or in any country, especially in the UK and the US, is maternal and fetal medicine. There is no fetal medicine on its own. So we are basically obstetricians who specialize in maternal and fetal medicine. So what happens is you do your 5-year training in obs and gynae first, and after that you do an additional 3 years in maternal fetal medicine. And the training curriculum is such that you do all the high risk obstetric clinics, like you do obstetric hypertension clinic, obstetric preterm labor clinic, you do hematology, obstetric hematology, obstetric neurology, um, and obstetric cardiology. So these are 3-month postings where you work with physicians who specialize in cardiology, neurology, and others. And then at the same time, you spend half of the time scanning and obviously picking up abnormalities, doing multidisciplinary meeting. So basically, what I'm trying to say is that fetal medicine is basically obstetrics. If you say to me, "Oh, can you do fetal medicine?" I probably don't know what that would mean, because for me, maternal fetal medicine is managing high risk cases which routine obstetricians would probably hesitate from, may not be equipped to do, or may not want to do. Because, as you know, you are in private practice, or many of you would be in private practice. And your routine private practice would mean that you would be looking after maybe majority low risk and some high risk women.
True. True.
In your practice, it would be very difficult for you to be looking after a lady who has very unstable rheumatoid arthritis or an unstable asthma, who often has acute asthmatics attacks maybe once or twice a month, in spite of doing everything that you need to do. Or somebody with a valvular lesion and in congestive cardiac failure, because that's simply you are alone in your setup, or maybe you have another 2-3 people.
Yeah. True.
And these are the type of people who need to be referred to maternal fetal medicine consultants, who basically don't work on their own. We usually have a big team. So if you ask me whether I would do this on my own, there is no way I can sustain this practice on my own. So we usually have a big team of of obstetricians, of fellows, of the whole multidisciplinary team. And that is basically what maternal fetal medicine is. It's basically managing high risk obstetrics.
Okay, and sir, when the role of a fetal surgery comes, like we diagnose the disease and we diagnose the anomalies, then how it is to be perceived by the youngsters, that because I know you had done the first fetal surgery. I will go into that later half of my questions. But what is the importance of when actually it should be done? In what are the conditions that has to be assessed prior?
So, fetal medicine is one of the youngest branches of medicine, and it is evolving very, very rapidly. We 10 years ago we used to talk about nuchal translucency, and there was so much of confusion and debate about all of that. With advancing fetal medicine, then we brought in MRIs. We were able to image babies better, and then the question was always that, is there something that can be done to correct abnormalities? And if you go back to the 1980s, it was the first time when Prof. Kipros Nicolaides and Professor E. Weil, they were fellows together, and along with Professor Stuart Campbell, who was their professor, and they first time put a needle into the mother's abdomen to test for amniotic fluid, blood transfusion, lasers. And you always want to push the boundaries. And even before that, if you look at Professor Harrison, Michael Harrison, and Robin Quintro, they are basically the originators of fetal surgery. The role that they played was putting in a camera into the mother's tummy and visualizing the baby. Laser coagulation of placenta is one of the, after fetal blood transfusion, laser separation of placenta for monochorionic twin pregnancies. for TTTS was another breakthrough. Then came the diaphragmatic hernia study, the total study, where we started doing the endotracheal occlusion. Once that was successful, the next step was to then say, okay, now what? And the next big thing that was coming at that time was spina bifida repairs, because the consequences of non-repair as compared to postnatal repair were serious. And then the MOMS study came as a breakthrough. MOMS was entirely a study that was conducted in the United States of America. And I think that brought a major change into fetal surgery. Gradually, as our confidence in operating on babies increased, now we are asking ourselves a question: what next? Which malformation can we correct
Corrected.
next?
Yeah.
Yeah.
Dr. Mandeep, I gone through the Netflix movie of a professor where he has shown an entire life history of his. So, if I just ask you, which part of your life will you can collaborate with the professor's lifestyle? Because I've seen how he is talking to the patients, what are the things need to be explained. So, tell me your one of the important that the patient you are going to remember till now, that the first patient you operate or first patient you done. So what is your experience that time, and what is your experience with the professor when you was with him?
Yeah. I think it's a long journey. If you go back a few years, when we went into medical school or when we were doing our post-graduation, for us, you were especially doing post-graduation, and I'm sure now as well, patients are not a business. They are basically part of your family. And your daily struggles, your daily happiness, and your daily sadness is because and associated with the patients and families. I think when you work with Professor, he keeps on saying the same thing, that medicine is not a profession. Medicine is a life choice, because you cannot dissociate yourself from your profession. It's a lifestyle that you choose. So if you choose medicine, his theory is very simple. Then you don't think about holidays, you don't think about families, you don't think about time off, you don't think about day, and you don't think about night. I'm sure that is his view, and I'm not saying that is the right view, because work-life balance is very important. You need to look after yourself, and you need to look after your families as well. But when we speak about Professor, his life was mainly and continues to be mainly research and fetal medicine. Um, uh, it was very normal for him to work up to 3 o'clock in the morning and then come back to work at 9 o'clock in the morning. And as fellows, we were all expected to leave after he left and come before he comes. Sleep, tiredness was not something that he would want to hear, or he would experience. The work that he did was so inspiring that we always wanted to be there with him to see all the procedures, whether it was laser, blood transfusion, or a CVS or an amnio. And I think that is the way Professor lives his life, and it's very inspiring because he has achieved a lot in his lifestyle. Coming back to what makes me happy or makes us upset is fetal medicine is a very unpredictable specialty, because the outcomes are not in your hands. We deal majority of the times with babies who are very sick, and when you're treating somebody who's very sick, there will be times when you would rejoice because of a good outcome, but there are always times when you would not be able to save the babies, or reduce the morbidity and mortality. And I think one of the other parts of maternal medicine, which has been very close to my heart, is bereavement counseling. Unfortunately, there are a lot of mothers who lose babies inside the womb, and they whether and I believe that whether it is in the West or whether it is in India or whether it is in the UAE, I think this group is neglected not because we don't want to look after them. It's just because we feel uncomfortable because we don't know the reason why babies have passed away. And I think that is the part that I have always enjoyed working with, because it's very fulfilling. Yes, we may not be able to change what has happened in the past, but there is a lot that we can contribute to and change for families just by giving them loving care, supporting them through this journey, and helping them plan for their next pregnancies or getting through it, is what makes a big difference. I think that is a part that I've always enjoyed.
Can you just tell me one of the uh, scene or one of the moment that touches you? Because being a IVF expert or maybe endoscopic surgeon, we always have a take home baby rate 30%. So we have the histories of early miscarriages, beta SCG, implantations occurring, but not a cardiac activity. So we always have I can correlate the feelings what you're talking to me, that we should be always see the what is the patient is going through. So similarly, can you just tell us what is your the moment that you are not going to forget, that the first moment or maybe any special moment that has happened with the patient in your journey?
I think I'll give two examples. One is from India, which I cannot ever forget, and one is from the UK, which again I will not be able to forget. So when I finished my post graduation, I always, as I said, I always felt that I was incomplete. I wanted to learn more. I wanted to do more, and I uh, looked at working in a big hospital in Mumbai. And when I was looking for a place, I met one of my physiology professors, and he said to me, "And Mandeep, Mumbai is a good place, but if you want to learn, then you either need to go to Yavatmal or you need to go to Dhulia, because those were places where nobody wanted to be at that time." And I said, "Yeah, I'm happy to go anywhere wherever I can learn." And he said, "Oh well, I know the dean there. I can ring him." And I he made a phone call, and there was a lecturer post available in Dhulia. And I took the bus next day and went to Dhule and joined there.
Oh,
As with any young person who comes out of medical school, we have read lots of things in the book, but we don't believe what we read. And Dhule was a very small district general hospital or civil hospital at that time. I was the only lecturer, and we had only one anesthetist and one professor who was a private practitioner but used to very often come. So my first case was a lady who had jaundice in pregnancy, and she was referred from an outside hospital, 37 weeks, and was in labor. So this was nighttime when she came in around 8 o'clock. I saw her, and she was put into the infectious disease ward because that's where jaundice in pregnancy was to be managed. So I rang my professor, and I said, "Oh, she's in labor, she's 4 centimeters, and I'm going to deliver her. I'm going to keep blood ready because she might have
yeah,
postpartum hemorrhage." And he said, "Oh, absolutely. And if there is any problem, let me know. I'll come over. But be careful, because my experience with jaundice in pregnancy is not good. A lot of women would not make it through."
true.
And he said that they would probably pass away after they have delivered. And I thought, no, that is not possible. How can that be? I've just seen this lady, and she's so aware. And I said,
Yeah,
"Okay,
going
fine.
to
I'll go
deliver.
and sit
Yeah.
with her. I will go and sit with her, and I will make sure that this outcome is good." And I sat with her throughout her labor, and she delivered, had a healthy baby, no postpartum hemorrhage. And I started suturing the episiotomy, uh, which I had done. And literally, while suturing the episiotomy, she developed encephalopathy and stopped breathing. Uh, and that patient I would never be able to forget. That and those are the patients that inspire me to continue doing high risk obstetrics. Similarly, if in the UK, it's about fetal medicine. I had a lady who had a monochronic twin pregnancy. And in monochronic twin pregnancy, we scan every 2 weeks because there is a risk of twin to twin transfusion syndrome. And uh, and we all assume that if I scan, or if I scan every 2 weeks, because we are good, nothing is going to happen.
Yeah.
So I scanned the lady, and uh, she had a monochronic twin pregnancy. One baby, MCA, was on the lower side, but both the babies were moving around. There was no other abnormality. She was 27 weeks. So I said, okay, fine. I was uncomfortable, so I asked her to come back in 3 days' time, not in a week's time, because that was the Royal College recommendation. Call them in a week's time. But I said, no, maybe I'll call her in 2 days' time. The parents said, is everything okay? I said, yeah, perfect. Everything is fine. Slightly reduced blood flow in the middle cerebral artery, but I don't know the significance of it.
Hmm.
And so in 2 days' time, she was to come in the afternoon, but she came in the morning and went to the ward. And I said, why are you here? Your appointment is in the afternoon. She said, oh, well, my baby is not moving. That is why I came to the ward. So I said, oh, come, let me have a look at your baby. And when I scanned her, one baby had passed away,
Oh.
and one baby's heart rate was just 40. And I did not know what else could I have done. And the parents obviously were distraught because they lost both their babies. Was very upset for a few days. But I thought, no, there has to be something that has caused this. So I contacted one of the perinatal pathologists who was he's one of the best in the world, Neil Saber, and asked him to look at the placentas. And he then, after 3 weeks, came back and said that this was an acute episode which could not have been predicted because the cord insertions were very close to each other. That is why there is no way you can predict or prevent this sort of acute twin to twin transfusion syndrome. So, what I'm trying to say is that there are a lot of situations where we think that we understand everything about medical science, and we can always predict what is happening, but nature will always come back and tell us that no, there is somebody
Yes.
better and
Superior.
superior
And
than you.
something is much more. Divine power is always there to
Correct.
teach us. So coming back to the now, I just was watching. You must be watching IPL. So Virat Kohli has done the best, and he made the last winning shot, and everything was in a happy mood. So the same feeling I must have seen on your face when your team done the first fetal surgery in UAE. So what was the experience that time?
I think it was a sense of achievement. It was good because we were doing the first surgery in this part of the world. Um, However, it's something that we still need to make good progress. Spina bifida, as I always say, this is not cure. This is more of palliation because these babies will still have some residual damage to
Hmm.
lower limbs or bladder and bowel. It is only good for parents who very well understanding the consequences of continuing this pregnancy, then decide that they are not going to terminate, they want to continue, and then that's the best option. So I think it was great. It was great to be recognized by colleagues from all over the world and from India. I would be much more happier when I do the first case in India, or somebody in India does
We
the
will
first
be
case.
waiting for the same because in India we have a good laparoscopic surgeon, excellent surgeons. We do surgeries of a different diseases, but still we are lacking in that particular. That's why my question was, when you are going to come down to India and train our juniors or maybe a fetal colleagues, expert colleagues to do the such kind of a surgeries. I know it is a teamwork. So, do you in a future thinking of something that is going to help in India to develop such a good clinic or maybe a center of excellence, and how the progress can be made?
I think with spina bifida repairs, I think it's not just about repairing the spina bifida. It's a lifelong commitment. The social structure, the support that these children need and these families need may last up to 18 years after birth and may be lifelong. So sometimes, and the termination laws are very flexible in India. Hence, majority of the couple choose to terminate pregnancy, which is okay. But I'm sure there are couples like your IVF couples who
Yeah.
probably have the only chance is having one baby, and if they choose, then those are the best cases to operate on. Absolutely. I'm looking forward to collaborating with anybody in India. I've been speaking to a lot of colleagues in India to be able to establish a fetal surgery center, not only for spina bifida, but for diaphragmatic hernias, but for lasers and many other. And there are colleagues in India who are doing good work. But it's always good to collaborate. It's always good to push the boundaries. India is the emerging power of the next century. We should not follow the West. We should be leading, and the West should follow us. And I think that's where we need to go.
Yeah, it's a, like a Hindustani speaking, and from the bottom of your heart. I really appreciate that the made in India and make in India. But coming down to the your another perspectives of life that I gone through the CV, which was really make me think that how the person of a OBGYN going into the fetal medicine, maternal fetal medicine branch, and after that going into some of the CEO levels, making the mergers of the different hospitals, developing them, making it one of the best hospitals in UAE. And I can see the one of the video wherein there is a on Burj Khalifa, the Burj Group has a name on it. So how this thing happened in a span, and what is the magic behind it, and what is the hard work?
I think management and leadership, it happened more of by accident. I never intended to go into management. But when I joined a hospital in the UK as a consultant after 2, 3 years, my colleagues asked me to become the clinical lead. And that's where my journey in management started. I became the clinical director thereafter. And then I met a professor from Harvard, and he used to teach leadership and management skills. I attended one of his lectures, was very impressed, and I met him and I said, "See, I'm a good clinician. I know that I can do clinical stuff, um, but I find management interesting as well." And obviously, he said to me that, "Mandeep, as a clinician, you can treat one patient. You can maybe in a day scan 15 patients. In a day, maybe in a month, maybe look at manage 200 patients. But by leadership, you can influence the life and outcomes of thousands of people because you are involved in making policies, directing policies, and making sure that the outcomes are not good just for your patients, but for other patients as well." And that I think struck me well, and I thought I will get into management, but at the same time, I'm not going to leave my clinical work. So all throughout my journey, I continued to be a clinician and went into management. We merged three big hospitals and their maternity units. I learned a lot. And when people think about management, they think it's something like you can learn. But why? What UK taught me that leadership is more about managing yourself rather than anything else. It's your behavior that impacts your colleagues, and we always need to be very careful about how we speak or behave with other people, including our patients. And obviously, in management, I was supported by a lot of people. Again, it's teamwork. We had a proper training program. We had a big management team. And of course, that was supported by professional management companies like Boston Consulting, KPMG, Deloitte, who would bring their teams and advisors. So the journey was very interesting in the UK. I came
Okay,
to
but
the UAE
yeah.
to
So
manage three
how it
hospitals.
comes down to from the UK to UAE?
Yeah. So the hospital in UAE contacted me because they had 16 different hospitals, and they wanted women's and children's services to be merged under one vertical. And that was the task that I was brought in for. But when I came here, I obviously had always been doing fetal medicine. So I started the fetal medicine unit here as well. We managed to bring a lot of changes into women's and children here, though the journey still remains incomplete because working in the UK and working in UAE is very different. This is a private healthcare model. And then, of course, the fetal surgical department that we started here made a big difference and took Burjeel Holdings to a different level, which they're very proud of.
Yeah. we are also proud of the saying that the person from India making a uh, the name in the international way. Just to ask you one thing, that we know we are good clinicians, but when you come down to the board meetings and everything, what actually makes a difference about our perspectives of the vision? Because we know as a treating physician or maybe a endoscopic surgeon what to operate, what are the steps. So is there is things that keeps on in your mind if you are going for the merging of the two different verticals. What is your perspectives and how that leadership quality, if anyone wish to perceive, because this is the podcast for all of us, those who are listening, those who are just passed out from MD or maybe are doing a practice, but they wish to go into the leadership qualities. Actually, what makes them, or what is the key factor that one should be pursuing on?
I think as doctors, we're very good at our work because we have been trained to do medicine, and that training lasts for maybe 12 years, 11 years, and we immerse ourselves day and night into our training. But when it comes to leadership, we always think, well, I don't need any training because what is there in leadership? I'm a doctor, I can do anything. I think that is one of the fallacies, and I think we need to. Leadership is a very different. It demands very different qualities, and I think we all need to be able to learn that. Leadership is more about self-regulation and about managing other people. Management is about creating processes and putting them into place. So these are two different things. Leadership and management are very, very, very different things. Just to give an example, if you do an MBA, you're good at management. But leadership is not MBA. Leadership is something that you need to develop because a leader is who brings all the managers together and shows them the way. So it's like I, as a leader, will say I want to go to the top of Mount Everest, but the managers need to create the way to go to Mount Everest. So that's the difference between
Yeah,
leadership and
true, true.
it's a very interesting journey, and I would encourage all my colleagues or people who are interested to look into management and leadership because as doctors, we will be the best leaders. And I think we lack medics in management and leadership. So I think that's something that my colleagues should strongly consider, especially the young ones, to be.
So another my question is like Dr. Mandip, you are an expert into maternal and fetal medicine. You had done so many things in a procedures of on the womb. Inside the womb, there is a patient of yours that is called as a baby. So where you are looking at this particular branch will lead into that whether we are going to, because in IVF we do NGS, we do a aneuploidies, we do a embryoscope. So we know that all the things are can be done at the embryological levels, but still there are certain things that will not is which is not in our hand. So we know that is this is going to happen, may not happen. Like there is a mosaicism, it's going to get corrected later on day 5 embryos, and then they get adapted to the uterine cavity. So similarly, in your branch, where you looking at the where is the progress and what is the next future in fetal medicine?
I think when when I finished medical school, age of viability, especially in India at that time and rural areas, we would consider as 28 weeks. Before 28 weeks, most of the babies will not survive. Then I went to the UK and the age of viability was 24 weeks. And when I left the UK, the age of viability now is 22 weeks. And that is how things are changing. We are constantly pushing boundaries. Fetal surgery was not known. For that matter, if you go back 20 years, 20 years, RH negative or isoimmunization used to be a big issue.
Big issue.
Many babies used to die because of hydrops secondary to anti-D antibodies. But today, fortunately, we don't see that. The number of blood transfusions have come down significantly. And I think that's where progress in medicine has made a huge difference. These are the babies that we save on a daily basis. But again, the progress comes at a cost. And I this is the point that I is probably for all of us to think is that are we doing more harm or are we doing harm as well managing these cases, because sometimes we are over enthusiastic in identifying abnormalities. Like, I'll give you an example, fetal medicine example. We look at the brain, we are supposed to look at three sections, measure them, and see if the brain anatomy is normal. We are supposed to look at the corpus callosum, but not measure it. If the corpus callosum looks normal, it looks normal. And the reason why we look at it, so that if there is an abnormality in the brain, then we are able to identify corpus callosum. There was a paper that brought a normogram of a corpus callosum. This paper came in 10 years ago by Gustavo Mellinger, one of the professors from Israel. 2 years later, he realized that there was an error, and he came back with another paper saying that please don't measure corpus callosum. If the brain looks normal, don't measure corpus callosum, because there is a variation of normal. That means it may
Yeah.
be small, it does not have any clinical significance if the rest of the brain looks completely normal. However, today a lot of people completely ignore that advice and continue to measure corpus callosum. And unfortunately, pregnancies get terminated because of this measurement, because of somebody thinking, oh, this doesn't look right. So today we may be losing a large number of babies who are completely normal just because we probably have been a bit more over enthusiastic. So I think this is something that we need to be very careful about.
Okay. So, like when I counsel my patients, like those are IVF patients coming after 10, 12 years of infertility, and they have a plenty of questions. We give a passionate advice to them, what to be done, what not to be done. So whenever you are going to do with the certain situations where the prognosis as a doctor, it is not going to be that great. So what is the key as a clinician that you will going to give a advice to the our younger generation that what they should be talking about, because as a doctor what is going to happen, because what is the good prognosis, what is the bad prognosis, but still in a good faith where sometimes we have to operate or we have to do certain things. So for youngsters, what is your advice how they should perceive this particular sympathy towards our patient, and what is your advice, because now you are a leader, now you are a known person in your own fraternity, and all over India is watching you 2 times now. So what is the advice Dr. Mandip will going to tell us to our newer upcoming generation of OBGYN?
Dr. Ashish, a very good question. And I learned this from Professor Nicolaides. I think as doctors, we always, or not as doctors, but as human beings, we always want to give good news. We don't like giving bad news. As doctors, if you're scanning, we always want to say everything looks normal. But if we find an abnormality, it is very difficult for us to say that there is a problem. And I think Professor always encouraged us to say, if there is a problem, he said that don't try and be a good person. Don't try and be the person who always gives good news. If there is a problem, tell your patients, talk to the patients. I think the second thing is that we always feel that our patients don't understand or our patients don't have an opinion. I think the thing that I learned in the UK was that the patients, whether they are poor, rich, educated, uneducated, all of us have the same level of understanding and emotion. Involving our patients into decision making is more satisfactory uh, than making decisions for them. As doctors, we are always guilty. We counsel our patients in a way that they would say what we want them to say. We call that as, oh, this is unbiased counseling. It's not unbiased. And I think involving them, involving families in discussion is very important. The other thing I realized was parents understand, families understand that the outcome is not going to be poor, and they accept that much more rapidly than we do. And once they have accepted it, they are your strongest support mechanism, because they then help you get through that difficult journey. So I think being honest and being open with families is not only helpful, it is also uh, more satisfying. And obviously, it reduces the number of complaints and the medical legal hassle that we do. I think one of the challenges in India is that we don't have enough time, in the sense we are dealing with large number of patients. But I think for the younger generation, I think that is the change that would need to come into our field, that we will probably need to spend more time with our families to be able to reduce and increase the satisfaction.
So Mandeep, Dr. Mandeep, we have now a couple of few minutes before ending of the podcast. Uh, can I ask you a personal question? Because we are Indian doctors. We trained in India. We are practicing in India. You was like a graduate, postgraduate from India. You moved to UK, and from the UK you moved to the UAE now, and you are heading the groups. So, do you think there is a difference of practice, medical practice, or maybe how you wish to see the Indian future doctors? Because it's as a you are as a visionary, what is your vision that the India is lacking? Because we know we are excellent surgeons, we know we can perform the things are, but we don't know how the Western world is looking at us. Because you have gone through the very different stages in a very different lead. You was a leader. You was into a guideline, different formations of the guidelines. So how you wish to develop these particular things in India? Because the youngsters should develop that mindset, how to go about it. Yeah.
I think the current generation is lucky and unlucky, both of them. Lucky in the sense because they have access to technology, laptops, computers, chat GPT, the best of books. We used to read books. Today's medical students probably don't read books. They have everything, either it's computerized or available in simulation. So I think the training is much, so they acquire knowledge much more easily and much more rapidly as compared to our generation. The disadvantage they have is probably we had more surgical training and time on the floor, whereas now, because of the number of trainees and the reduced number of postgraduate teachers, because I think there is a lack of postgraduate teachers in India, there is a mismatch, and that is why our younger generation is probably not getting the same amount of experience that we got
Used to. Yeah.
10, 15 years ago. So I think that is probably the disadvantage. However, what I would suggest to the younger generation is that when you finish your MBBS and when you finish your post graduation, don't think that that's the end of the journey. Unfortunately, medicine is such a profession that you need to continuously learn and innovate, and always think about the bigger picture. I think I'm not going to say that all of you should go abroad.
Mm.
India has a very well-developed education system. I think it's about exploring different
Yeah.
specialities,
Yeah.
exploring different modalities that are available. And of course, if you have an opportunity of going and working abroad for a few years, whether it's Singapore, whether it's the West, whether it's the US, then of course do it. No exam is difficult. There is nothing that is impossible. We have, as Indians, we have been able to break through in every
Yeah.
branch of science, not just medicine. So I think we're very lucky to be where we are, and there's nothing that is not achievable.
Dr. Mandeep, when we walk on the seashore, we always left behind our footprints to walk on the same path. Maybe younger people who are our kids, they used to in a very young kids, they walk on the same path, and they just follow us. What is your take? Because this may be my second last question. Last question will be something different, but this is my second last question to you. That you had walked through the seashore, you had left your footprints on the seashore, and the few of them, they are following the footprints of yours. What is the next journey where I will see Dr. Mandeep Singh will be achieving or going to achieve in future?
I think that's the regret, that I have not been able to, like, yes, there are people in the West who have trained and they are doing well. But my regret would be not being able to have the opportunity to train people in India. So I'm still young. I think I've got another 10, 15 years to go. So next plan would be to do something in India and have a group of doctors that I could personally train and see that footprint, that so-called the footprint that you say in
Yes.
India that I would leave.
Okay.
But I'm doing my best to be able to do so. So yeah, let's see what the future holds.
So my last question, because now we are talking somewhere around 45 minutes now. Dr. Mandeep, this is the organization of more than 42,000 gynecologists. Those listen to this podcast, those are watching Dr. Sunita Tandulwadkar, leadership qualities, you as a leader into a different branches of medicine. As you mentioned, the leader has a different qualities, and it has to be perseverance, as has to be like how you trained yourself, and it is started from the self belief. What I wish to ask you that whenever you are is in India is the largest body of OBGYN in FIGO. We go in a different conferences. We go into the ISHRE as far as our IVF is considered. We go to the AHL for the endoscopy to upgrade our things. What is your take on having the conferences and where you are seeing that this particular conference as a fetal medicine or as a OBGYN one must attend and one like going to the Makkah and Medina, the usually the people do of those who are belong to the Muslim communities are for us. We go to the Gurudwara, we go to the so what is in fetal medicine where the youngster should learn and should watch and should also perceive their education.
I think there are two parts to attending any conference. Like when I was a young doctor, conferences were a platform for two things. One is to gain knowledge, of course, to gain the latest updates, but also to see great leaders that would inspire us to achieve big things. I remember when I was doing my post graduation, a team from Wadia Hospital came to Kolhapur, Panhala, to do a 1 day workshop. And I went there and I was so inspired by that group that inspired me to achieve a lot in obstetrics. Similarly, conferences happen across the world. There are a lot of conferences in India, and there are a lot of foreign faculties that come. There are a lot of good, big leaders in India, good obstetricians in India, good fetal medicine people like India. And I can't stop but mention Dr. Suresh's name. He's been there. Like even when I was doing my post graduation, I used to go and attend his lectures. So there are people who will inspire us even in India. And of course, there are conferences abroad like the World Congress in Fetal Medicine, which is in Prague this year. There is the ISPD conference. There is the Society of Fetal Medicine conference in the US. These are the three big conferences that happen throughout the year. So of course, knowledge is one, updates are one, but inspiring or seeing people whom we would want to be is equally important.
I think of friends and my colleagues, this was Dr. Mandeep Singh, who is doesn't I think now doesn't require any of the introduction formal to all our audience because he is now just a name kafi hai. So I think Dr. Mandeep, it's really a pleasure of mine to take an interview with such a great personality in the field of medicine. And always this podcast will be there for the people to get inspiration from your talk and to achieve the goal what they wish to have. So thank you very much from the Foxy team and from myself that accepting this for the second time and being there in our lives to give us a advice about the knowledge and about how the life should be. Thank you very much for being there.
Thank you, Dr. Ashish. Pleasure to be part of this podcast. Thank you.
Thank you. Thanks a lot.